Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Sowa University Hospital, professor of medicine, University of Khartoum. We are still doing our session in basic emergency care course. This is the second session in difficulty in breathing. Objectives, as I mentioned in the first session of difficulty in breathing, we would like to recognize signs of difficulty in breathing, list high-risk cause of difficulty in breathing, perform critical skills for high-risk causes of difficulty in breathing. Before we do the secondary survey, we should have finished the primary survey. So we should have completed ABCD exam and treat any life-threatening condition before going for extensive examination. While we are doing the secondary survey, if we find any issues related to ABCD or life-threatening conditions, then we stop and go back to ABCDE. In the secondary survey, look, listen, and feel. Patient with difficulty in breathing may present with tachypnea, change in respiratory rate, change in respiratory effort. There is use of accessory muscle and depth of breathing. In addition to that, they will have low oxygen saturation in the blood, and that can manifest as change in mental status. In secondary survey, look for sign of respiratory failure or what we call respiratory distress. Patient is using the accessory muscle. There is increased work of breathing. He has difficulty to speak full sentence. He cannot lie flat on bed. There is sweating, diaphoresis, mottled skin. Some people are confused, irritable, and agitated because of hypoxia. And there is poor chest wall movement and cyanosis. Look at the pupils. A small constricted pupil could be due to narcotic overdose or exposure to pesticide. Irregular and unequal pupil can indicate raised intracranial pressure that could be related to trauma or tumor or bleeding inside the brain. Look at the face, nose, and mouth. Cyanosis around the lips, nose indicate low oxygen level. Pale lower eyelid may suggest anemia. Swelling of the lip, tongue, back of the mouth can suggest anaphylaxis and allergic reaction. Soot around the mouth or nose, burned facial hair or facial burns suggest smoke inhalation. Bleeding, swelling, or abnormal airway shape may be due to trauma. Look at the neck and chest. Distended neck veins can suggest heart failure, tension pneumothorax, or pericardial tamponade. Excessive muscle use of the neck and chest indicate respiratory distress. Shifting of the trachea could be due to tension pneumothorax, massive pleural effusion, or tumor. Swelling of the neck can suggest neck infection or hematoma due to trauma. Examine the entire neck, chest carefully for sign of trauma. Look at the rate and pattern of breathing. Longer exhalation time could be due to asthma, narrowing of lower airway. Fast breathing, tachypnea can happen with dehydration, severe infection, acidosis and chemical imbalance, poisoning, and anxiety. Bradypnea and slow respiratory rate and shallow can be seen in opioid overdose. Flail chest can be seen as paradoxical chest wall movement. Look at legs. Swelling of one leg could be due to DVT, and swelling of both legs could be due to edema, heart failure, or renal failure. Look at the skin. Bite can signify allergic reaction. Presence of rash can be part of an allergic reaction. You can see hives. Pallor can signify anemia. Burn that wrap around the torso can restrict chest wall expansion. Then you listen for breath sound. Stridor, partial upper airway obstruction can be due to foreign body, swelling, trauma, or infection. Decreased breath sound, this can be due to pneumothorax, hemothorax, presence of fluid, foreign body, or infection inside the lung or tumors. Lung auscultation, when you hear wheezes, it could be due to asthma, allergic reaction, partial obstructing tumor, or partial obstructing foreign body. Presence of crackles can signify pulmonary edema or lung infection. Listen to the heart sound. Abnormal heart rhythm can cause the heart to pump blood poorly, lead to poor perfusion. Presence of murmur and difficulty in breathing could signify valvular disease. Muffled and distant heart sounds with low blood pressure and fast heart rate and distended neck vein can suggest pericardial tamponade. Then you feel the chest deformity or abnormal movement suggests rib fracture. Presence of crepitus could be due to pneumothorax and subcutaneous emphysema. Unequal chest expansion can be seen in pneumothorax, hemothorax, or flail chest. When you percuss, presence of dull percussion note can indicate massive effusion or hemothorax. Hyperresonance indicate pneumothorax. After we do the primary survey, sample history, and then we go to secondary survey, then we want to put the sign and the information together to highlight possible causes of difficulty in breathing. Presence of foreign body leading to airway obstruction usually present with acute difficulty in breathing, visible secretion, vomit, or foreign body. Abnormal sound, you can hear stridor, snoring, gargling. Patient can have cough and drooling. Those with severe allergic reaction usually see swelling of the lip, tongue, and mouth, stridor and wheezes, rash or hives, may have tachycardia, hypotension, and there could be history of exposure to certain allergens. Airway swelling could be due to inflammation or infection. Patient can have stridor, hoarse voice, drooling, or difficulty swallowing in severe cases, unable to lie flat, and may have fever in case of infection. Airway burn, history of exposure to burn, fire, or chemical. Facial burn, you can see that. You can hear stridor and change in voice. Patient with pneumonia can present with fever and cough, gradually increasing work of breathing. There can be pleuritic chest pain, and with auscultation you can hear crackles. Patient with asthma or COPD exacerbation, they present with wheezes, cough, use of accessory muscle. They can be sitting in the tripod position, and there could be history of asthma or allergies. Patients with pneumothorax usually have sudden onset. There might be a history of trauma or evidence of rib fracture. There is decreased breath sound on the affected side and hyperresonant percussion note on the affected side. They could have pleuritic chest pain. Those with tension pneumothorax can have hypotension, distended neck vein, and decreased breath sound on one side. Hemothorax, there is decreased breath sound on the affected side, dull percussion note on percussion, and they can have history of trauma, cancer, or tuberculosis. Those with trauma and acute massive bleeding can present with feature of shock. Acute chest syndrome, it happens in patients with sickle cell disease. Usually they have history of sickle. It could be the first presentation. They present with chest pain, which is diffuse, fever, and hypoxia, and there could be feature of concomitant infection. Heart attack, it's a recognized cause of difficulty in breathing when it leads to pulmonary edema. Patient can present with chest pressure, tightness, or crushing feeling in the chest. Cardiac cause of chest pain. They can have diaphoresis, mottled skin, nausea, vomiting, sign of heart failure and pulmonary edema, and they could have risk factor like smoking, cardiac disease, hypertension, diabetes, high cholesterol, or family history of heart disease. Heart failure is the recognized cause of difficulty in breathing. Patient can present with exertional dyspnea, orthopnea. He cannot lie flat. There could be swelling in the leg, distended neck vein, presence of crackles in the lung, and if it is due to heart attack, they can have chest pain. Cardiac tamponade. Patient can present with shock and poor perfusion, tachycardia, tachypnea, hypotension, pale skin, cold extremities, and increased capillary fill. At the same time, they have distended neck veins, muffled heart sound. They may have dizziness, confusion, or altered mental status. They could have risk factor like tuberculosis, trauma, cancer, kidney disease, or it could be secondary to trauma. Anemia can present with difficulty in breathing secondary to heart failure. Patient can have pale skin, you see that in the eyelid, tachycardia, tachypnea, history of hemorrhage, malnutrition, cancer, pregnancy or infection, or tuberculosis or renal failure. Patient with opiate overdose, they can have history of use of recreational drug, altered mental status, and even coma, change in pupillary size, slow, shallow breathing. Other systemic causes of difficulty in breathing, like anemia, opiate overdose, also diabetic ketoacidosis. Patient could be non-diabetic or could be the first presentation, present with cosmal breathing, frequent urination, sweat, smell of the breath, high blood glucose, and urine and presence of ketone plus dehydration. Take home, in patient with difficulty in breathing, always start with primary survey, do A, B, C, D, E. Whenever you find an abnormality, fix it before you move on. After you stabilize the patient, take sample history, and then you go into detailed secondary survey. While you are doing the secondary survey, whenever there is abnormality or critical issues, you have to go back to A, B, C, D, E approach. In the secondary survey, you look, you listen, you feel, and you do thorough exam to identify pulmonary causes of difficulty in breathing, cardiac causes, and systemic causes. And we'll continue in the second session to know how to manage patients with difficulty in breathing.